So thank you again, everybody, for joining us. And we are also live streaming on Facebook. I think we have just gone live. So hello to everyone joining us on Facebook. Okay, yeah, we're gonna get started. So again, we're really excited to have you here this afternoon. For anybody that may have missed it as we were getting started, this is Improving Treatment for Obsessive Compulsive Disorder, hosted by NAMI-NYC, the National Alliance on Mental Illness of New York City. Again, my name's Clara. I'm going to start us off by just saying a couple of words about NAMI-NYC before I turn it over to our speakers. I'm also going to be moderating the chat and collecting questions for our Q&A at the end of the event. I do see there's a question there about the link to the Facebook live stream. I don't have the link myself, but if you search NAMI-NYC Metro on Facebook, you'll find our page, and this live stream should be one of the first things that pops up. In a minute or two, we will be able to share that link for you as well. I see another question. Is there a certificate for attendance? No, there is not. Thank you for that question. Okay, so I would love it if folks could introduce themselves and say, or just say where they're joining us from. It's always cool to get a sense of where our audience members are calling in or joining us from on Zoom. We've got over 200 people in this Zoom room, and it looks like we've got folks from New York City, San Francisco, Virginia, Las Vegas, Missouri, upstate New York, Buffalo, Connecticut, Chicago, bunch of folks from New York, Brooklyn. I'm in Brooklyn, so shout out to Brooklyn. Some folks from New Jersey, Canada, really exciting. I'm sorry I'm not able to call out everybody because we've got so many people here, but I'm just putting a few highlights so that folks can get a sense of how many people are joining us. Got a couple folks from Australia, Ireland, from across the pond, so welcome. Okay, so thank you again, everybody, for being here. NAMI-NYC, the host of this event, the National Alliance on Mental Illness of New York City, is a grassroots mental health organization. Our mission is to provide support, education, and advocacy for all individuals and families impacted by mental illness. What that means is that we have classes and support groups that are offered free of charge for people who are dealing with their own mental health issues, and also people who are supporting somebody in their life who may be struggling. We know, and I certainly know from personal experience, that folks who are struggling it's really useful. It's really nice to have people in your corner, in your support network, who can be there for you. And it's also can be stressful to be that support for somebody else. So we want to make sure that folks are getting that support for themselves as well. All of our classes and groups are facilitated by peers, which means that, for example, our support group for people living with anxiety and depression is facilitated by people living with anxiety and depression. Our support group for parents of children and young adults is facilitated by parents. Our support groups for family members are facilitated by family members. So we're really trying to create a space where people can share experiences and hear from people who share experiences with and hear from other people who are themselves struggling with similar things as what you're struggling with. So that's sort of what we do in a nutshell. All of our programs are currently being offered via Zoom, but we look forward to the day that we can have groups and classes in person as well. All of our services are free of charge, and you can find out more by calling our helpline, which is open 10 a.m. to 6 p.m. Monday through Friday. That number, which I'm also going to put in the chat in just a second, is 212-684-3264. You can also email us at helpline@NAMI-NYC.org. You can also always go to our website at NAMI-NYC.org, and I encourage you to check out our calendar. That's where all of our support groups are listed, which don't require pre-registration, so you can just click on the link and join there. We also have events like this one listed, our educational events, which cover specific topics in more detail. Okay, so that's my introduction. Now I'm really pleased to be able to introduce our speakers. We have today Louis Horowitz, a high school English teacher, basketball coach, a father of a 13-year-old daughter and husband to a wonderful wife, who began working as an advocate and activist in the OCD community in 2015 after attending his first national OCD conference held in Boston. We also have Dr. Sapana Patel, Associate Professor of Clinical Medical Psychology and Psychiatry and Director of Services and Implementation Research at the Center for OCD and Related Disorders at Columbia Psychiatry and the New York State Psychiatric Institute. And we have Dr. Blair Simpson, Professor of Psychiatry at Columbia University Medical Center and the Director of the Center for Obsessive Compulsive and Related Disorders. So I know that was a lot of, a couple of mouthfuls, but we're really honored to have them with us here today. We're really excited to have you here today to learn from them. And to hear from you all. As I said, we will be having a Q&A at the end, so do feel free to put questions or comments in the chat, and I will be keeping track of those to share with our speakers at the end. Okay, so Louis is going to be starting us off, so I am going to go ahead and turn it over to him.
Hi, everyone. I wanted to open up with a disclaimer that OCD symptoms can come in many forms, and my experiences with these symptoms in no way reflect my views towards any group. Intrusive thoughts don't reflect one's values or align with who they are. When I was 18 and in the second semester of my freshman year at college, something seriously changed in my brain. I certainly did not know then what was going on, but it was my first bout with OCD, specifically HOCD, homosexual OCD. One night, I couldn't perform during sex, and my girlfriend said to me, "Maybe you're gay." From that point forward, a switch was flipped on, and I couldn't turn it off. Prior to this night, I had never really considered the possibility of being gay, but the moment this particular girl said those words to me, the "what if I'm gay" obsession commenced. It wasn't just the thoughts spinning around, but the bizarre and disturbing imagery that accompanied the thoughts. Then came the persistent and uncomfortable bodily sensations. In my gut, I didn't feel like this was really about my sexuality. Something else was going on, like my brain was suddenly hijacked by a stranger. I withdrew from friends, was in a constant state of stress and anxiety, couldn't sleep, had difficulty concentrating, and overall, I no longer recognized myself. After some encouragement from family, I started seeing a therapist on campus, sneaking in and out of his office so no one would see me. When describing the specific obsessions and sensations, this therapist was perplexed. After a few sessions, I stopped going as the experience only exacerbated my feelings of hopelessness. I moved back home when the semester ended, attended community college, where I discovered the outlet of writing poetry. Seeking further professional help, I remember finding a decent therapist who I liked talking to, but he also didn't quite understand what was going on with me. I remember him encouraging me to explore my sexuality, an approach offered by most therapists I saw over the years, but incorrect for HOCD. The thought of being gay was based in fear, not desire. But up to this point, none of the mental health professionals had mentioned anything about OCD. A couple of years passed and I felt stable enough to return to a four-year college and pursue my education to major in psychology. I wanted to better understand myself and my situation. OCD ebbs and flows. It had ebbed. It also morphs. The flow was on its way and I didn't see it coming, but OCD was ready for another battle. And this time its weaponry was ants. I started imagining ants all over my body, in my shoes, on my keyboard, in other people's mouths when I talk to them, in my food, and on, everywhere and all the time. The ants transitioned into more general obsessions of contamination. One day a plumber came over to fix the kitchen sink, and I ended up throwing out all the food under the spell that he deliberately contaminated everything in the refrigerator and pantry. I knew I was being irrational, but I couldn't stop myself from behaving this way. I once again dropped out of college, this time to check myself in at the psych ward of the county hospital. I spent a week there, and still, no one mentioned OCD. A few years later, I had another relationship where HOCD attacked me again, and stronger than ever. I became convinced I was gay and did not belong in this relationship with a woman, although a few months prior, I proposed to her and we moved into an apartment together. After about 3 months, I told my fiance that I was gay, but it was really the OCD telling me what I wanted. Devastated and lost, I attempted to check myself back into the hospital, but this time they didn't admit me. Continuing in outpatient therapy and returning to medication, I finally had a therapist suggest it sounded like I was describing OCD symptoms, but I wasn't ready to hear that. I'm now going to turn it over to Dr. Blair Simpson.
There we go. Hi, everybody. Thank you so much, Louis, for sharing your story and starting this off. I've been asked to talk about what the scientific literature tells us about OCD. So I'm going to take a few minutes to tell you a very quick summary. So what is OCD? Next slide, please. The first thing I want to say is OCD is a disabling disorder. The prevalence, meaning how frequent it is, it's about 2 people in 100 will have OCD in their lifetime. And if you think about it, it's 1 in 100 have schizophrenia. So it's always interesting, which is people are surprised to find out that OCD is more common than schizophrenia. Half the cases start by age 19. And if you look at that in comparison, half the cases of major depression start at age 32. And with OCD, 25% of the cases start by age 14. So you hear that in Lewis's story, is that it's sort of at this period of childhood or adolescence or just going to college that half these cases start. Just as Lewis described, typically the symptoms are chronic, but have a waxing and waning course. And finally, if you look at the seriousness of the symptoms, a vast majority, when people have OCD, the symptoms are moderate to severe. That's really in distinction to some of our other anxiety disorders, where often the symptoms are mild. That's not the case of OCD. So if you add it all up, how common it is, that it can often start in childhood or adolescence, that once you get the symptoms, they're sort of there with you chronically, coming and going, and that typically the symptoms are moderate to severe. That's why this disorder can be so disabling. Next slide, please. And then what are the hallmarks? What are the symptoms of OCD? And it's in some senses a very simple illness. So it's amazing how People go for years without being properly diagnosed. To have OCD, people have obsessions and people have compulsions. Well, what's an obsession? An obsession is a repetitive, intrusive thought, image, or urge that's intrusive and distressing. You heard from Lewis the thoughts he had that he might be gay. That was a very distressing thought to him, not one of desire, but distress. And then he described quite clearly the images he had of ants. So all of that can be obsessions. And then the other symptom are repetitive behaviors or mental acts, which are the compulsions. These can be things like washing and cleaning if someone has contamination concerns. They can be, people have terrible doubts and uncertainties that can be repetitively seeking reassurance. So those are obsessions and compulsions. And the key is the symptoms are distressing, time consuming, and impairing. We all have funny little thoughts from time to time. People will often check twice to see whether, let's say, they have a train ticket as they're going out, but that's not OCD. OCD is more than an hour a day and impairing. Well, that's the simple part of OCD. But the complex part of OCD is that the types of obsessions and compulsions different patients can have can really vary. And there's a range of content and fears. So a lot of people know about the contamination type of OCD, concerns about getting ill, washing a lot, but they're not aware of the whole range of symptoms that people could have, which Lewis just described some of that range. So people can have concerns about contamination, about harm, about symmetry or exactness, about taboo thoughts. It's a big, complex disorder once you actually talk to an individual. People can also have different affects. Some people get a lot of anxiety and panic. Some people get a sense of it's just not right. There's this discomfort because it's not right. Other people can get a feeling of disgust. And finally, there can be varying insight. And what I mean by that is some people, Lewis said is, I knew it didn't make sense, but I couldn't stop myself. So that's, if you will, rational good insight that these symptoms didn't make sense. But sometimes people can have no insight at all and to really think it's true. And finally, OCD often doesn't occur by itself. People can have other anxiety disorders, people can have depression, some people can have tic disorders or eating disorders. And it's that heterogeneity that sometimes I think can trip clinicians up and make them not understand this whole thing could be OCD. Next slide, please. So people often ask me what causes OCD, and the simple answer is we don't exactly know yet. But what we do know from a whole group of studies that have been done over the last 20 years is that people with OCD, when you compare them to people who don't have OCD, have alterations in very specific circuits in the brain that serve different neurocognitive function and behavioral function. And so the hypothesis, the working hypothesis, is that people with OCD have varying alterations in these different circuits, and depending on the degree of alteration, that might give the different flavor of OCD across different patients. But that's not a very satisfying answer in some ways, because we don't use this yet to make a clinical diagnosis, and we don't use this yet to actually precisely develop treatments, but that's the goal. And it's also true that we don't know, well, why does one person get OCD with these alterations, but let's say their brother or sister doesn't get OCD, even though they share some genes. So what's the risk and what's the resilience to OCD? This is really an unanswered question. And the next slide shows this is actually one in our research study that we're taking on. We're partnering with 4 sites all around the globe, South America, the Netherlands, South Africa, and India, to sort of try to understand, if there really are signatures of OCD in the brain, you should find them not just in my clinic in New York, but you should find them all around the globe when someone with OCD walks in. And it's also true, we really want to study people with OCD and people who have a brother or sister who doesn't have OCD, to try to look at what's same and what's different, because that might help us better understand risk and resilience. But I'm sure what most of you are interested in is, how do you treat OCD? So that's the next and final section that I want to tell you about. So there are two evidence-based treatments for OCD. One is treatment with medication. It's a class of medications called serotonin reuptake inhibitors, and it includes an old-fashioned antidepressant called clomipramine, and it also includes what are called selective serotonin reuptake inhibitors, and the names are all listed there. All of these medications on this slide work. They've all been shown to work in what is the gold standard way to find that, which is what's called a randomized controlled trial, where you randomize some people to the treatment and you randomize other people to, let's say, a sugar pill, and you have people who don't know what people were randomized to rate symptoms over time. And all of those medications have been shown to be better than a sugar pill in randomized controlled trials. And that's why we use them in OCD. But really importantly, the other evidence-based treatment we have and has also been studied in randomized controlled trials for OCD is a very particular type of psychotherapy called cognitive behavioral therapy, but even a very particular type of that, which is called exposure and response or ritual prevention. And it has different acronyms in the literature. The next slide will describe briefly what that is. What is exposure and ritual prevention? Well, it's sort of in the title, right? What you do in the treatment is you make a hierarchy with one of your patients who has OCD of all the things that trigger their intrusive thoughts and their desires to ritualize. And you, in a very systematic way, expose them to those triggers while coaching them how not to do their rituals at the same time. So that's the exposure and the ritual prevention. And it's really important that they be done at the same time. And what do we think we're doing? We're trying to disconfirm the fears and challenge the distorted beliefs. So we're trying to work on the cognition. We're also trying to break the habit that people with OCD have developed of ritualizing and avoiding. And most importantly, the goal is to improve functioning and quality of life, because when you have those intrusive thoughts all day long that are causing you to stop your life and you can't get out the door because you're ritualizing all day long, you can't go to school, you can't go to work, you can't really be fully present in a relationship. So the real goal of this treatment is functioning and quality of life. Excuse me. There are many different formats the way you can give this treatment, but the typical one is actually quite short and brief. You take 2 planning sessions and then you do 15 of these exposure sessions. But there's a lot of homework and home visits to promote the person really learning how to do this. And the way I like to say it is, the goal of the treatment is that you become your own therapist. Excuse me. Sorry, something has wafted in the window. Okay, next slide. So which is better, the medications or the therapy? How would we even know what's better? Once again, it's one of those randomized controlled trials. So I'm showing you data from one of the trials that we did a long time ago now with Edna Foe at the University of Pennsylvania. And this was a trial where we recruited people with OCD and we brought them into our study. And some people got a sugar pill, and that's in yellow. Some people got the medication clomipramine, and their results are in red. And other people got the therapy, either alone or with the clomipramine. And that's what you're seeing in these lines. On this axis, which is the y-axis, is OCD severity, and a 16 and above is considered significant symptoms needing treatment. And you can see everybody comes in quite high. That's moderate to severe OCD. On this axis, which is the x-axis, is treatment week. And what you can see is if you got the sugar pill, your symptoms really didn't change over 12 weeks. If you got the medication, you had a nice slow decrease in your symptoms. But look at what happened if you got the exposure therapy with or without the medication. You had a dramatic decrease in your symptoms. The treatment there was delivered intensively over those first 4 weeks with much lower symptoms when you went out to 12 weeks than either of the other 2 conditions. So this is to show you just how powerful that cognitive behavioral therapy can be, either with or without the medication. One of the keys of that treatment is it doesn't work unless you do the homework and you really work on it. It's much more like learning a new language. You know, you could go to Italian class and hear a teacher speak Italian, but if you don't memorize the words and practice Italian outside the class, you don't get very good at the language. It's sort of the same with cognitive behavioral therapy. So next slide. So studies like this allow us to put together what we call a treatment algorithm, which is what's a sequence of treatments, and everything in white is where you should start. So if you're someone or you know someone whom you love has OCD, really they could start with a therapy. If they're really going to do it, the data are very powerful, even for it alone. If people don't like the idea of the therapy because it's tough work, because you have to expose yourself to what you fear, some patients would prefer to start with a medication to bring their symptoms down. And if you still have symptoms after either of those treatments as monotherapy, you can put the two treatments together. And the data we have from other studies suggest just those two treatments alone, half of people can get well. I mean, really, not just lower symptoms, but well. But then the question always is, what about the other half, right? And the other half are these other boxes. The green box is adding other medications. There's variable data for this. Most of the studies done there are small. The data where there's the strongest for is probably adding what's called an antipsychotic medication, but those medications also have side effects. If that doesn't work, there's a lot of experimental treatments that are going on. One thing that happened just in the last 2 years was that the FDA cleared what's called deep transcranial magnetic stimulation for the treatment of OCD. It's one of the first treatments that the FDA has cleared or approved in many, many years. There's a lot of research going on at my clinic and around the globe on other types of medications and treatments. And just to put it out there, there's a very small section of people who, no matter what we try, the treatments that we have in the white boxes or the green boxes or the yellow boxes aren't working. And there's a very, very small group of people who actually come forward and have neurosurgical interventions to help their OCD. But I think the important message is the message of what's at the top, which is cognitive behavioral therapy and medication treatment with serotonin reuptake inhibitors, either alone or together, can be highly effective for many people. And so it's really worth, if there are people listening who haven't had those treatments, it's really worth starting there and having optimism that you can make your life better. Here's the problem though. Most people don't receive evidence-based treatment. And my colleague, Dr. Patel, is going to talk more about that.
Thank you, Blair. So everyone who's listening, we now understand that it takes people quite a long time to understand their symptoms and to seek help. And we now know that there are some very powerful treatments for OCD. And we're faced with a challenge within our healthcare system, specifically for individuals with OCD, because what we know is that based on research, we know that most with OCD do not receive evidence-based treatment, specifically the very powerful cognitive behavioral therapy that Dr. Simpson has just told us about. So why do we think that is? Well, we've done a lot of work over the last 10 years in partnership with Dr. Simpson and her Center for OCD and Related Disorders. And we've also done a lot of work in partnership with the New York State Office of Mental Health to really understand why is it that people aren't getting the care that they should be getting. We know that from our work and from our research, as well as working with individuals with OCD and their families over the year, that the issue lies at two places. One is that individuals may not know that they're experiencing OCD, and Lewis very elegantly explained his experience in getting to the right place and understanding what his experiences were. And there's also a reluctance to disclose the symptoms. Oftentimes people, as we know, have a range of experiences with respect to their OCD symptoms, and they may not be willing to share that. There may be reluctance due to shame, guilt, a lot of different feelings associated with symptoms. And some people may not know that what they're experiencing isn't really happening in reality. We also know, as Lewis explained, that providers may not recognize OCD, and there are a variety of reasons for it. It presents in many different ways, and people may misdiagnose it for other illnesses like anxiety or schizophrenia, for example. We see that a lot in the literature. And as a result of not recognizing it or misdiagnosing it, people may not treat it. So I share the statistics with you all that from the time of diagnosis, it takes on average 11 years for an individual with OCD to receive treatment. That's quite a long time compared to other illnesses that have a much shorter duration of untreated illness. For example, schizophrenia is about 2.5 years. So we thought to ourselves over the past decade or so, how can we tackle this issue? There are clear gaps in care for people who are suffering from OCD, individuals as well as their family members. What can we do to improve and address this gap, both for individuals, but also for providers? And that's where I'll tell you a little bit about in the next few slides about a program that we've developed to improve the quality of care for New Yorkers with OCD. It's called Impact OCD, Improving Providers' Assessment, Care Delivery, and Treatment of OCD. And here's what we're doing in this program. We want to raise awareness about OCD. We know that this needs to happen not only for the individuals that are out there suffering from this illness and their families, but also for the people who they may see in a clinic or in a school setting. We want to train frontline clinicians, and it even goes beyond training frontline clinicians. We want to raise awareness, and we want to train folks in different settings where people may be speaking about their symptoms or seeking help. So that includes clinics, it includes healthcare settings broadly, it includes school settings. And we want to teach them what to really recognize what is OCD and what do I do if I think that I'm encountering someone who is describing these symptoms, and how do we get them to the right care? We also want to create and curate resources for individuals and their families. The work that we're doing is a partnership between the Center for OCD and Related Disorders and the Center for Practice Innovations at Columbia Psychiatry and the New York State Psychiatric Institute. And we have been extremely fortunate to have our work supported and partnered with the New York State Office of Mental Health and their commitment to increasing awareness, training clinicians, and really creating a better system for individuals with OCD has been a gift. So in the spirit of co-creation and making sure that any type of policy or program is really aligned with those who are the people who are receiving services and those who are providing the services, we have advisory boards. So we have stakeholders that include families, individuals with OCD. We have providers who are on the front lines of care. We have leadership from behavioral health agencies and community clinics. We have our leadership at the New York State Office of Mental Health. And we convene our boards regularly to make sure that we are developing our program and the materials and the resources to support our program, that it's very much aligned with the perspectives of all of our stakeholders. So I'm going to take you through the next couple of slides that'll tell you a little bit about what we're offering in this program. First is an OCD toolkit. We wanted to arm individuals with resources to know where to go, to get help, and to really understand and educate themselves about OCD. So we have an Impact OCD toolkit, which is on our website. I'll be happy to share the website with this group after, but it includes resources for providers as well as individuals and families. And you can see across the bottom of this slide that we have an array of resources really to help clinicians understand what is OCD and how do we treat it. And for individuals and families, we really want to arm folks with treatment tools, directories of where to get treatment within the state of New York. And we partner quite closely with the International OCD Foundation, which is an advocacy organization, to really help people get connected to the resources that are available, not only in New York, but nationwide and internationally. We've developed some e-learning modules. Now, this is where we're really trying to target our clinicians and our providers. We want them to understand how to detect and diagnose OCD. What is exposure and response prevention? How do you treat OCD pharmacologically? What are the medications? And also, how do you tell the difference between OCD and schizophrenia? And that's a really important special topic that's emerged from our providers, which it really was sort of a question for them often. How do we know the difference? So we've developed these e-learning modules for our provider community. And we also have a support service where a frontline clinician, if they're sitting in front of someone and they're not really sure about what is happening, but they have a sense that it might be OCD, they have the opportunity to connect remotely to a clinician within the Center for OCD and Related Disorders and ask questions about assessment, psychotherapy, or medication. And this is a service that we've been offering, and it's been really interesting and also very rewarding to be able to work with clinicians and answer questions and to support their work in the community. We are now embarking on our newest endeavor to really develop these types of resources and materials for children and families as well. And we'll be developing a toolkit, and we'll be developing more e-learning modules for this group as well, because we really want to be able to provide a program that addresses the experience of OCD across the lifespan. So I want to summarize and say that what we've heard is that OCD can be a debilitating disorder, and that evidence-based treatments are not used, but we're working. And what's really important is that the advocacy and the education and research are needed to be able to ask questions about why these treatments aren't getting into the hands of clinicians, arming our individuals and families with information. All of these things are needed so that we can identify people early. We know that early detection and increased access make a difference. And that's really what our program is about. I want to turn it over to Louis, who's going to tell us about his trajectory to wellness and how access to evidence-based treatment can make a difference. Louis?
Thank you, Sapana. So I'm going to pick back up with my story. I kind of brought you through my 20s here, and now I want to take you through my 30s and lead you to when I finally got the appropriate treatment. So at the age of 31, during another relationship with a woman, she became pregnant and we had a daughter. 6 months later, we got married. HOCD returned, and I developed a drug habit to survive the strained marriage. Drug and alcohol abuse quite commonly ebb and flow along with the OCD. 2 years later, I was divorced, and my daughter ended up with me full time, as my ex needed to work through some of her own demons. OCD ebbed again as my daughter required all my attention. And it was interesting how it allowed me the space to be a father, at least temporarily. One main reason I fell in love with teaching and then being a father was because when in these roles, I was outside of my head, not in my obsessions, and OCD went mostly dormant. For years, it continued like this: teaching, coaching, parenting, living a decent life. I started responsibly weaning off meds. I got into long distance running, living well, eating healthy. But I was still too frightened to return to the dating and relationship world. I now had an ex-fiance and an ex-wife. So I resigned myself to living a life that was manageable, sometimes good, but certainly not complete. OCD wouldn't allow me to have a full life. The summer of 2014 was the beginning of the end of this 20-year cycle. My mother was sick and not getting better. OCD was creeping back in, and I broke up with yet another girlfriend. My ex-wife and I were having some custody issues. I was completely off any medication and not going to therapy. When my mother died that September, 4 days before my 38th birthday, and almost exactly 20 years after my first OCD symptoms, I spiraled out of control. HOCD returned full force, and this time I attempted online dating with men and wrote a coming out letter to my family and friends. I kept thinking, my mother just died and all I can think about is sexuality. This doesn't make any sense. Why can't I just grieve the loss? What was fascinating was that as soon as I told my family and friends that I was going to pursue living as a gay man, I no longer felt gay. What I would later discover is that I was unknowingly engaging in one of the most effective exposure therapies I would ever perform. Yet, excuse me, OCD is viciously clever and vindictive because as soon as the fear of being gay was subsiding, the obsessions had to morph again, and they did, returning to bugs, but this time spiders. My two anchors in life, teaching and fathering, were no longer holding me at bay, and I was terrified because I had so much more to lose than ever before. Fortunately, the girlfriend I broke up with, who is now my wife, someone I did not want to lose, remained loving and supportive and encouraged me to take some of my inheritance money and apply it to my mental health. I remember her questioning me. Why are you not learning everything there is to know about OCD? I had denied the truth for so long and allowed the OCD to imprison me in a paradoxical comfort zone of guilt, shame, and fear. Similar to Stockholm Syndrome, I was psychologically convinced I needed my captor OCD. Who was I without it? I was finally ready and determined to find a way out of this OCD trap. However, what I didn't know is that the only way out of OCD is to go directly through it. In February of 2015, 20 years after first displaying these symptoms, I went to my very first OCD specialist. It was Dr. Alan Wegg at the Stress and Anxiety Services of New Jersey in East Brunswick. OCD is proficient at deception, and even after all these years, I still wasn't convinced I had OCD. But by the second session with Dr. Wegg, who presented himself more as a coach than a therapist, I was mostly convinced I had OCD. A great weight was lifted. I am not broken, crazy, disgusting, cruel, and whatever else this disorder was telling me I was. A separation was made. There is OCD and there is me. The work began with the concept that in order to find the light, I had to navigate through the darkness. When listening to our intuition, we run from fear. I had to go counterintuitive and go directly towards the fear. I was officially diagnosed with OCD and severe clinical depression, this comorbidity being very common for OCD sufferers. CBT, exposure and response prevention, ACT, acceptance and commitment therapy, along with mindfulness practices, appropriate medication, and a work ethic were all part of this treatment plan. Additionally, the psychiatrist I found was the first one in my mostly all negative experiences in this field, who really took the time to understand my issues and apply specific and careful approaches. But this was also the first time I took the time to find the right psychiatrist. It works both ways. The first task was to begin scripting, writing out the obsessions and measuring the levels of anxiety, also known as SUDs, subjective units of distress. Dr. Wegg had me really attack the OCD in this department. Don't hold back, be relentless, exacerbate the thoughts on purpose, Show the OCD that you can create the thoughts as well, not just be a victim to them. I put so much disgust and guilt and shame on these pages and had to sit with it, but it was being placed somewhere else outside of my head. Using visuals was also a strategy, looking at pictures of disturbing images that already filled my mind. OCD is one of the most debilitating disorders out there, but also one of the most treatable, if done correctly. Also, I learned that obsessive tendencies can be helpful and work to your advantage when applied in a positive way to treatment. I read every single book there was out there on OCD. I scripted beyond what was required. I completed mindfulness workbooks. I was precise with medication and so on. In a way, I was using OCD to overcome my OCD. After a little more than a year with Dr. Wake, he told me I didn't need him anymore. I was equipped with the tools to go out on my own, and he was right. I was. If OCD flared up, I had the knowledge and resources to handle it appropriately. Advocacy work came next. Dr. Wegg put me in touch with a 20-year-old patient of his who was struggling mightily with HOCD and asked if I would talk to him. We met at a diner, and within the first 15 minutes of conversation, incredibly, it was like we shared the same brain. We are still extremely close and have become like family to each other. I've served as a mentor to him for years, but he has done just as much for my healing as I have for his. Summer of 2015, I attended my first national OCD conference in Boston and learned a ton. My then girlfriend, now wife, came with me so she could learn more about OCD as well. It's certainly not always easy to be the partner of someone with OCD. This level of support was crucial in my recovery. The following spring, I spoke on a panel at a local New Jersey conference sponsored by IOCDF, the International OCD Foundation. I was absolutely petrified, but I did it. OCD was not going to stop me from airing out all its dirty tricks. I call the shots now. On May 18th, 2019, I remarried, and I'm still married. We went to Costa Rica and explored the country. We own a house and live with our teenage daughter and 2 dogs. Sometimes I don't recognize myself in the very best way. OCD is still around and pops up from time to time, but it doesn't bother me much. I keep it in the background, and sometimes I even forget I have OCD. When it doesn't let me forget, I can handle it with my acquired skill set. OCD is a worthy adversary, a formidable opponent, and I give it credit. I invite it in, and I don't run from it because I can't. OCD is my worst best friend, and sometimes we still need to hang out with each other, but not for too long, because now I have more important things to do. That's the end of my speech.
So at this point, thank you so much, Louis, for sharing. I'm sure there's about to be lots of love in the chat coming your way, but we've got a couple moments not a couple moments, we have some time for questions at this point. And I have some questions saved up. I know, thank you, Blair, for addressing some of the questions in the chat, but I know we have some outstanding, so I'm gonna get right to those. So let's see. So there were a couple of questions about different other diagnoses and how they might interact with OCD. Specifically, one person said, my daughter was diagnosed with OCD while attending college approximately 10 years ago. More recently, her current psychologist told her that her symptoms were more of someone with ADHD and anxiety. Can you talk more about the comorbidities that hold hands with OCD, which is a lovely phrasing. Yeah, so let's start with that.
So I can address that, which is in adults, the most common co-occurring disorders with OCD are other anxiety disorders like panic disorder, social anxiety, generalized anxiety disorder, specific phobias, or depression. So those are the big ones. But in fact, you can also have co-occurring eating disorders. In people with schizophrenia, 12% can have comorbid OCD. It's often unrecognized and untreated. In bipolar disorder, people with bipolar disorder, 10% can have OCD when the actual baseline rate is 2%. And then in kids, there's often this triad that we see, which is tic disorders, ADHD, and OCD, typically more in males than females, but that's this sort of conglomeration of disorders. But and then that obviously complicates the presentation and it complicates the treatment. Someone asked that question, and the sort of bottom line I would say is, you look at the person in front of you and you look at what they're struggling with. And if it's straightforward OCD, then it's straightforward. You start with those medications and the CBT. But let's say they have OCD and PTSD. You have to really understand both disorders. And sometimes you have to figure out which one you're going to approach first, right? Because you don't want to start doing exposures for OCD that trigger someone's PTSD, for example. That would be an example of, or you have someone who's so depressed, they're not going to do all that homework. Like, you got to treat their depression so that you can actually ready them to actually take on their OCD, right? And then again, I always like to remind people, we all have stuff. Like, life is tough, life is uneven, right? Whether you have mental illness or not, life goes up and down. And we also have lots of just real life issues. So the goal of the treatment of OCD, from my point of view, is how to get OCD out of your life, so you can go on with your life, like how to get it out of, because as you said, Louis, it's mean. It has this really nasty way of getting in there and really mucking with people's sense of confidence and security. And the goal is to get the OCD out of it so you can deal with the regular issues of our uneven lives, right? I don't know if that helps, but that's what I would say.
I think that's great. Sapana or Louis, did either of you want to address that question as well?
I would need the question repeated.
Just talking about comorbidities and other disorders or diagnoses that may overlap with OCD. Not sure if that was part of your experience or not.
Well, yeah, I mean, when I went to my first OCD specialist, and I went through some evaluations for depression, and he said maybe 90% of OCD sufferers also suffer with depression, and said it in a very simple way, because it's depressing to have OCD. So so it was kind of a bit twofold with my treatment. It was first work on the depression as well, in addition to the OCD. Because the less depressed and the more confident I was, the better chance I had of really engaging in the treatment and being productive with it. But the depression can put you in a place where you feel as if you don't have the confidence to do the ERP and the CBT and go after it that way. I could say another one, comorbidity. I saw someone in the chat about the ants and hallucinations and this and that, and I just wanted to clarify one thing, is that it was all imagination. There was not one time where I actually really believed that anything was there, even though I had sensations and it was in my mind, but I knew the difference. But it was sometimes misconstrued in the mental health world as some form of psychosis, and I was put on antipsychotic drugs at certain times, and but I knew the distinction. I did, and that's a really powerful distinction when it comes to this, I think.
Really quickly, one other question about, sorry, I think just for the sake of time, I'm gonna jump on to the next question, if that's okay. I'm sorry, Sapana, were you
Okay,
gonna?
that's fine. That's fine. Go ahead.
Sorry. So there was also a question about hoarding and OCD, what the connection is there.
Do you want to take that, Sapana, or you want me to take that?
Go ahead, Blair.
So historically, hoarding behaviors, collecting and not being able to discard and excessively shopping was historically considered part of OCD. And then when people started to look at all the different symptoms of OCD, and what they looked at was like they grouped. And when I describe, contamination concerns, harm concerns, symmetry, those are called dimensions. Now, inside contamination, one person can be afraid of ants and another person can be afraid of the city of Baltimore. And I've had patients of both. So that's, like it's a big world inside contamination, but they were divided into these different dimensions. One dimension that came out was hoarding. And that got people really looking at hoarding disorder again. And now there's actually a separable diagnosis called hoarding disorder. And I would just like to make this point though, which is there are people who excessively shop and can't discard. They really don't have intrusive thoughts and obsessions in their head. They don't really have rituals in this sense. That is what hoarding disorder has become. But people with OCD can still have hoarding behaviors. And I'll give you an example. Someone can have concerns about doing harm. This is a real patient of mine years ago, concerns about doing harm. So she had to keep every single section of the Science Times from the New York Times because there might be an article in there by some author who it might actually help somebody someday. So her apartment became completely full of newspapers, but it really was OCD behavior, if that makes sense. So once again, and I guess I would make that same point, which is an intrusive thought doesn't mean OCD, because there are other disorders that have intrusive thoughts, right? Like depression can have ruminations, right? And a repetitive behavior doesn't make OCD. There are other disorders that have repetitive behaviors like skin picking or trichotillomania. Likewise, hoarding behavior in its own could be hoarding disorder, could be part of OCD, can also be part of dementia. So when we look at a human behavior, the question is what's the best way of explaining what's causing the behavior? Because then that is what you want to go after to treat it. That was a long answer to say they're related and they're different, I guess, is the simple answer.
There's a question about, so I just want to say it is 6 o'clock now. We can go for a little bit after the official end time of the event, if that's all right with folks, to address some of these questions, but we will be cutting off at 6:10. So just so everybody has a sense of what's coming. So there was a question about genetics. Is OCD genetic?
That's an interesting question. So big picture, when you think about what causes any illness, think about breast cancer. I think it's the best model right now. It's been studied so much, right? There are a couple of genes that have put people at really high risk for breast cancer, BRCA1 and BRCA2. But their contribution to all the breast cancer cases is tiny, tiny. It only accounts for a tiny amount of cases. Then there's some genes in breast cancer that put you at risk, but not risk like that. And then there's some genes that seem to interact with the environment. I think that's how people should think about genetics underlying disease, and including OCD, which is maybe one day there'll be some rare genes that in some people really are the guiding point. But my guess is it's going to end up like breast cancer, which is the vast majority is going to be genes that put us at risk or put us at resilience. And then what matters is what happens in your environment along the way. And so that's the goal. So to date, there have been a couple of genetic variants that people have gotten interested in. There's just now a new paper of a gene called SLTRK5, which there's a mouse model of. But we're in the very early days of understanding the genetic risk of OCD, in part because the samples are still too small.
Thank you. There were a couple of questions about specific symptoms, which I think kind of goes back to the question about comorbidities, but I think maybe we can reframe the question a little bit. How would one be able to tell if specific intrusive thoughts or, fears are related to OCD? One person brought up the example of feeling like an outsider in social situations, or like those intrusive negative thoughts about socializing. Another person brought up constant health concerns. How can one sort of distinguish intrusive thoughts more generally versus intrusive thoughts specifically related to OCD?
I don't want to dominate. I'm happy to answer, but I don't want to dominate. So,
Well, I can say something about that. So one rule of thumb that I always use when I'm speaking to individuals about this, which is oftentimes when you're having an intrusive thought and it's fear-based, what really distinguishes OCD from other things like social anxiety is if in response to the actual intrusive thought or image or fear, a person feels driven to perform some sort of compulsion. And so Dr. Simpson explained what a compulsion is. So most people who experience obsessions will also experience compulsions. And these are not just behaviors that you can always see. They're not overt observable behaviors. There are also, and important for people to ask and to share, that there are mental compulsions where a person might feel like they will repeat certain words over and over. They will count up to a certain number in their mind. And so typically a person with OCD, I always ask, are there things that you do when you to respond to the anxiety that you're having? And if they start talking about compulsions, either mental or physically observable compulsions, more than likely it's OCD. Whereas with some of the other anxiety disorders like social anxiety disorder, they may also avoid, they may have increasing levels of anxiety and not be able to stay in the situation. But really the compulsion piece of this is really the distinguishing factor in terms of a diagnosis and a differential diagnosis.
And I could say one small bit about that is after all these years, I was unable to before, but I can distinguish now between what's inappropriate fear and an inappropriate fear, or a rational fear and an irrational fear. And that took quite a while, but I feel like I can do that now.
Thank you both. Yeah, that's I think a great addressing this question. There were a couple of questions about finding a therapist that specializes in exposure response prevention. Can you talk a little bit about how to find this kind of treatment, how to make sure that it's covered by insurance? And just talk a little bit about that. I know I had shared a link in the chat to the resource that we are also going to send out after for finding therapists, but if we can talk a little bit about that and share any resources in the chat, that would be awesome.
I can just say one encouraging thing is that when I first started treatment, I had to go out of network for both my OCD specialist and psychiatrist, and each of which cost about $250 per session, and that was once a week. But I was getting reimbursed by insurance in due time, so I was able to navigate my way through that.
I mean, I guess I would say is I think this is a huge challenge because I think our mental health system is so disconnected and not serving people well, regardless of where you are on the economic spectrum. And I think that people with this expertise can go into private practice, and then there are huge amounts of money that they're charging, and then that becomes a barrier. I can tell you, if anyone's listening, Sapana and I would like to set up a remote EXRP service for New York State. We just need someone to fund us, and we have a whole model that we would like to actually deliver, but we realize that we need sort of a fairy godmother to give us the resources to do it. Because the other data that we have, which is from COVID, which is really great, is actually, you could really do this stuff by telehealth. And that suddenly makes it much more available to people, right? Which is if people can do it by telehealth. And then Sapana and I have also been working with people around the globe who are looking at digital interventions. So we're lucky in New York City. There are quite a number of specialty places that do this type of treatment, that some of which have sliding scale. You can actually get pretty good treatment, but I am very, very sensitive to the fact that across the United States, that's not necessarily true. The International OCDF Foundation has a part of its website where you can go on and try to find someone with some expertise in OCD, but there are many, many places where people can't get access to this specialty care, which is why Sapana and I happen to be excited by the opportunity of telehealth or digital tools to increase access. But we need someone to want to pay for them. So.
And I would also say, just to add to the question, sometimes people don't know if what they're getting is actually exposure and response prevention, right? So in our toolkit, we have a couple of resources that we include because, exposure and response prevention, when you're getting it. And a lot of what we've learned from doing some of our consultations is that a lot of people think they're doing it, but they're not doing it, or they're doing it EXRP light. And it's really important, as you heard from what Lewis said, that you really got to stick to the treatment and be taught by someone who's a coach and is going to take you through the treatment appropriately. So I think just to Blair's point, to be able to increase access and reach and really think about scaling this treatment, in addition to what we're doing with the public mental health system right now, I think those are avenues for the future that really merit further sort of support and discussion around, because it is really hard to train people in the community to do this treatment well. And that's what's required. So just to add that.
Absolutely. So I know there are more questions that we have not been able to get to. And I'm very, very regretful to cut us a little bit short. But I do want to let everyone know that there will be additional links and resources going out after this event. If there are any, there was one question that before we wrap up, I just want to address because a couple of people asked about a link to the toolkit. And I put the link in the chat, but it does look as though it requires some sort of login to get into the link. So I don't know if
I can say something about that, Clara. So there's a couple of different parts of our program. One is those e-learning modules that I discussed. And those are specifically for clinicians and providers within the State Office of Mental Health system. So that's one aspect. The other aspect is the toolkit, and that is completely forward-facing for individuals and families as well as providers. And the link to that we will be sending after this, but that is something that's available without needing a login or anything like that. Our e-learning resources, given that we're funded by the State Office of Mental Health, are behind a learning management system that not all folks have access to, but the other resources that we have on our website are freely available.
And if I can make a plug, which is not only for treatment and early intervention, and I think that I'm not a child person, but I think in particular, parents don't look away. If you think that your kid is showing symptoms of OCD, go early is my opinion, and go see if you can get them CBT, and do it before they spend 10 or 20 years doing this stuff over and over again, because I don't think that's good for your brain, right? So go get them something. And again, you don't have to worry. It's not medication. It's CBT. It's about, it's like a coach, as Lewis said. It's like getting yourself in shape. It's getting your brain in shape. I really encourage, whether it's anxiety or OCD, go early. And then the second thing, and if there are any of the listeners out there who want to help us advance the science, you know, please go to our website and look at what we're doing, and it changes all the time. And what we want is better treatments. We want to increase access for the people who can't get the treatments now. That's part of the research we do. And then we also work on what are new treatments for the people who've tried all this stuff and they're still not well, because we need better treatments for them too.
Absolutely. I think that's a great note to end on. We're so grateful to our speakers. Just so grateful to all of you for being here, for your wonderful questions. I'm sorry we couldn't address everything, but hopefully this was useful. Please feel free to share the recording when you receive it later this evening. There is the public toolkit, which was just shared in the chat. Thank you, Sapana. So we have a lot of resources available out there, and we're just really grateful for all of your participation and for your presence, just to share this information out further. Thank you all so much. And thank you
And
again.
thank you to Clara, who put it
Thank you.
together, and for giving us this opportunity to speak to people about OCD. Thank you so much. Back to NAMI. And to everybody who listened.
Yes, thank you all for joining today.
Exactly.